And I said to her, you know, obviously different centers run different ways, but I know at your center, you guys focus on, you know, you have a big focus on research.
Yeah. Yeah, so she's one great, and you know, I met her and I met Leslie and I met other people through the BRCA Strong. And it's interesting that if I think about everyone that came from BRCA Strong was in a minority group. So, and it's interesting how they feel, even the perception, you know, one of the other ones, since we're waiting for other participants, was just this shock of going in surgery, thinking you have a stage 0 and coming out of surgery with a stage 3. And that distrust I need the ocean to wash that. And Dr. Yepes is on the call. And, you know, we all know that you make the best guess pre-surgically. And then at the time of surgery, the real truth comes out, not because somebody missed something. Right. But when you put that into a context of mistrust and having this perception that you may be taken advantage of, becomes even more relevant in some ethnic groups. It was really interesting to observe that. So unfortunately, I won't be able to stay long. I see Dr. Luceta, who I met through your group, and we've been talking, you know, on social media, but we haven't met in person. So I see she's on the call, and I would love to meet with you one day.
Yeah, and, I'd love to have that thing.
She's definitely been our supporter. I could say our girls love hearing her talk. Come on, we're actually going to be putting a program together. We'll give you guys a heads up once it's all together, but we're going to do a program where we do 2 sessions, like 1 week or 2 in a week, to kind of take it to the next level. Like, obviously no medical advice can be given, but just to try to be there and support women a little more as they're going through their journey. So we're going to put together like a class, I guess, for women. So once we get that together, we'll let you know and make sure we keep you informed.
Yeah.
Perfect.
So I want to thank Dr. Yepes for joining. I know there was, you know, we've been talking, and I'm going to leave you now because I'm going to have to be done for the clinic. But it's nice seeing you all, and thank you.
Nice seeing you. Thanks, Dr. Jalpa.
Bye.
Okay, bye.
So what I'm going to do is I'm going to mute everybody on the call and we'll get started.
So,
oh. So I will do a short introduction and then I'll pass the mic over to you.
Okay, very good.
Perfect. Good morning. Thank you everybody for joining. My name is Tracy Milgram Posner. I'm the founder of BRCA Strong, where we inspire, educate, advocate, and support survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. We do that by funding post-mastectomy garments and lymphedema sleeves and pillows while you're going through your surgical part of your journey. During COVID-19, we are not doing any events. We normally do transformational photo shoots, fashion shows, yoga, and just come together in a community where we all feel safe and could talk about our journeys. But during COVID-19, we've obviously been unable to do this, and we are mailing packages to women who are going in for surgery, who are starting their surgical journey or treatment. So if you or a family member need anything, you can feel free to reach out to myself, Kate, or Tammy on the board, and we'd love to support you. Today, we have Dr. Monica Yepes on, who is on for National Mammography Day. Now, this day to me really stood out as we want to bring more awareness to our community on mammograms, and we are so thankful for your time and dedication and really appreciate you coming on.
So thank you very much. Thanks for having me, and it's a pleasure to be here today. I'm very passionate about education and bringing all this information to everyone, and especially making sure that everybody knows what they should be having, when they should be having it, and where you can do what you need to do in terms of screening. Okay. So I had put together a PowerPoint, right? And I make it quite interactive. So I mean, if there are so few of us, I think we can all leave our mics on so that everybody can kind of participate, okay? All right, so let me just open up here. Oh wait, did you give me, let me do my share. Okay, all right. Okay. All right, do you see it?
Yes.
My PowerPoint? Okay, very good. All right, so we're going to talk a little bit about breast cancer. You know about it, but just like very briefly, the importance of early detection, what the guidelines for breast cancer screening are, facts and controversy, screening for high-risk patients, and we'll talk a little bit about risk factors and prevention. Okay, so I like to start out with a little quiz. I like to get the feel of what people know, what they think, and that kind of helps me segue into the discussion, okay? So there's only 3 of you, so you're gonna all have to speak up. All right, okay. So screening does not change the chance for survival due to breast cancer, true or false? And so I'm not gonna give you the answers. I want you to just kind of.
False.
False.
Okay, very good. Wait, why is this? Huh, okay. All right, when should women begin to screen for breast cancer?
It depends.
How often should women screen for breast cancer?
Every year.
All breast cancers are the same and have the same prognosis.
False.
False. False.
My probability of surviving breast cancer does not depend on the size of the tumor.
False.
Yeah.
Most people who get breast cancer have a family history of breast cancer.
No.
False.
All people who have genetic mutations have a family history of breast cancer.
False.
False.
This is like a really savvy group. Mammography is enough for all women.
False.
False.
Mammography should never be performed during pregnancy. Ah, stumped you there, didn't I?
It's false if the.
Well, because the radiation normally, I don't know.
Okay. At least I can teach you guys something, right? And you can never develop breast cancer.
False.
False. False.
If I have a genetic mutation, when should I start screening?
Varying on when you're, it's varying on the age of your earliest diagnosis in your family, right?
Okay, all right. So that's just kind of like the segue, and we'll start touching on a little bit on each of those subjects, okay?
Perfect.
So let's go into the facts. So you know that on average, 1 in every 8 women will develop breast cancer in the course of their lives if they live to be 70 in the USA, right? But this is average, okay? We know that some groups will have more than that, right? And unfortunately, there are many new breast cancers per year, and unfortunately, we still have a lot of breast cancer deaths, correct? So what is breast cancer? You know what it is. It's a rapid growth of abnormal cells. The breast in general has 2 major structures, which are the ducts, which is what transports the milk to the nipple, and the lobules, which are the little sacs where milk is formed, okay? So these are the lobules, and these are the ducts, right? Think of it like the pipelines that take the milk from these little sacs towards the nipple, because, I mean, that's what breasts are for, right? And so this is looking at that duct as if we did like a cross section of it. And so we see these cells, these are the normal ductal cells, and this is kind of like the open space, right? So what happens? So most breast cancers are ductal cancers, so they occur within those pipeline structures. And so this is what a normal duct should look like. But as we go from normal to cancer, we see how the empty space starts filling up with all these abnormal cells, right? And we go from normal to hyperplasia, which means hyper many, so many cells. And then we have atypical ductal hyperplasia, which means that the cells are becoming abnormal. You see how these nuclei, which are the central component of the cells, start becoming different sizes and shapes. And then we move into in situ cancer. And so this is the membrane of that duct. This is like the wall of the duct. So in situ means that these cells have not breached the wall, whereas when it becomes invasive, those cells breach the wall of that duct. Okay, so it's kind of like the whole spectrum. And the same thing will happen within the lobules, okay? So those are the two major kinds of cancers that we're looking at. So you know that there are different risk factors that affect the probability of having breast cancer. Obviously, gender. Females are going to be much more likely to have it than males. Age, the older you are. The family history, of course, is important. It does affect your risk. The presence of genetic mutations, as you all know. Obesity, because it does increase the amount of hormones that are circulating in your body, and also increase inflammatory components which facilitate the cancers to be more aggressive, okay? Alcohol intake, as much as 1 glass a day increases your risks as much as having a first-degree relative. Hormone therapy, of course, does increase the risk, and lack of exercise, okay? So these are all things that increase risk factors. So let's talk about screening now. So does screening reduce mortality? And so if anything has been in the news is the controversy of whether screening works or does not work. They've been a little bit quieter over the last couple of years. I think politics and COVID have taken over. But normally about this time of the year, every year, this controversy comes up. So why is it controversial? We know that before we were doing screening, the only way to diagnose a cancer was when it became clinically evident, right? And for a cancer to become clinically evident, it usually means that it was a larger tumor, at least 3 centimeters in size, which is like 1.5 inches, right? And by the time these cancers are larger, they have a higher likelihood of being more aggressive and a higher likelihood of having spread to the lymph nodes or other parts in the body, right? So this was kind of like the norm before we started screening. And unfortunately, what that meant was that we were treating advanced late-stage tumors. But once we started screening, we started finding clinically silent tumors. So what does that mean? You still can't feel them, you still can't see them, they're not causing nipple retraction. And so only half of them are invasive tumors when we do good screening. They're much smaller. Instead of being 3 centimeters, they're up to 1.5 centimeters, so less than 1 inch still. Less of them will be aggressive, and less of them will have spread to the lymph nodes, right? So that's kind of like the goal, because what we want is to find very small tumors, or what we call precancerous tumors, like the in situ, that DCIS, where it still hasn't breached that wall, the wall of the duct, because that means that they're going to be a lot easier to treat, right? And so not only does that improve mortality, right? So when we find a precancerous lesion or a stage 1 lesion, your chances of survival are going to be much better. So not only does it increase your chance of survival, it also improves the type of treatment options that you're going to have. So for example, if you just have DCIS, then a lumpectomy may be enough. But if you have a 3 centimeter or larger tumor, you may need a mastectomy, you're going to need radiation, you're probably going to need chemotherapy. So a lot more things need to be thrown in there for that treatment, the larger that tumor gets, right? So let's just look at the guidelines for average women, for women of average risk. So you're supposed to start clinical breast examination every 3 years between the ages of 20 to 39. And so the self-examination, there's been controversy over that as well, but it's a good idea. I promote it. I think that if you find something, if you know your breast tissue, you're more likely to find something small than a doctor who only examines you once a year and doesn't remember whether you're lumpy bumpy or not, right? So the idea is that you should get used to your lumps and bumps. And ideally, you want to do that self-breast examination like a couple of days after your period, right? So never during your period, never right before your period, never in the middle of your cycle, because your breasts are going to be lumpy because of all those hormones, right? So once your period is done, that's when you should be performing that self-breast examination. And if, for example, you don't have breasts, or you don't, I'm sorry, if you don't have a period, if you're past menopause, choose a day of the month where you want to do that. And so you know what to look for. We're going to look for lumps, changes in the size or shape of the breast, areas of pulling, retraction, nipple discharge, changes in the skin, areas of discoloration or dimpling, thickening of the skin, and any abnormal lumps in the axilla. So these are the things that you should be looking for when you're doing that self-examination. So for women of average risk, screening begins at age 40. and annually. So this is kind of like where most of the controversy has been, whether they should start at 40 and do it start at 40 and do it every year, or wait till 50 and do it every 2 years. So why is it controversial? Because there are so many different entities that are trying to opine and rule over mammography. And you've probably heard of the USPSTF. Has everybody heard of them? So it's the United States Preventive Services Task Force. And so what they do is they review the guidelines for all these screening modalities, and they look at them from a statistical point of view. And what they concluded was that even though mammography does reduce mortality by 16%, which is a big number in women from ages 40 to 49, because it's less common than in older women, it means that you need to do more mammograms. And so it's more expensive, right? It yields less number of cancers per mammography performed, but that doesn't mean that it doesn't work. It does work, right? And that's the bottom line. And that's what women need to understand. It's, you are not a statistic, you are a patient. And for you as a patient, screening early does impact mortality, okay? And so we have randomized control trials that have shown improved mortality, and we also have large population-based studies. So for example, in Sweden and in Canada, before mammography became universal, they had counties where some counties did offer screening and others didn't. And when they looked at the data from those counties, 20, 30 years later, they're still finding that those that started screening early had a much greater reduction of mortality than those that didn't, as much as 50%. So that's huge, right? So that's kind of like the take home. We do have to screen, okay? So there is unequivocal evidence that mammography reduces mortality, okay? So anybody have any questions on that? All right, so how do we?
I have a quick question about the self-breast exam during, like, if you're breastfeeding, like, is it as reliable? Like, is it something?
I'm sorry, if you're breastfeeding?
If you're breastfeeding, because I mean.
Oh, yeah, so that's tough. So during breastfeeding, there are a lot of things that start popping up, right? And so it gets a little scary, right? So, but the normal thing during breastfeeding is that things should be coming and going. So when you feel a lump that's an obstructed duct, which might be like the most common thing, right? It should go away, right? If you put warm compresses on it, massage it, and you're pumping or feeding that baby, it should go away. If something persists more than a week and does not go away, you need to go and ask. And that's one of the things that I'm going to talk about, okay?
Thank you.
But that's a great question. So yes, mammograms are uncomfortable. Nobody likes to have a mammogram, right? And we compress because we care, okay? We don't do it because we're sadistic. It's because we need to compress. We need to make that breast thin so that we're sure it's not moving around, so we get the best images, and so we can give less radiation. The smaller the breast is when we compress it, the less we have to radiate it. So we compress because we care, okay? So who needs to do early screening? We're not all the same, right? And just like treatment options are trying to be individualized, we're trying to individualize our screening as well according to your risk factors. And so we want to know what your risk factors are. So when you come in to get your mammogram, we ask a lot of questions. And it's not because we're busybodies, it's because it helps us make a decision as to what the best routine for screening is for you. So who should be doing early screening? So obviously anyone who has a first-degree relative under the age of 50, right, should begin 5 to 10 years prior to diagnosis. So for example, if mom was diagnosed at 45, daughter should start at 35, okay? Anyone who has a genetic mutation, so especially BRCA1 and 2. So the recommendation is no earlier than 25 and no later than 30. Okay, and how we make that determination depends upon the age of presentation within your family. So some BRCA patients families have later presentation breast cancer, so they can start at 30. Some have very early presentation, so they may need to start at 25, right? And usually what we recommend is between ages of 25 and 30, we want to start with MRI, not with mammography, because unfortunately, especially BRCA1 patients may be a little more sensitive to radiation. So we want to try to minimize that, okay? Patients who have had chest radiation as part of treatment. So for example, some patients get lymphomas, chest lymphomas at a very early age, under the age of 30. And so when they get radiated to the chest, that radiation can predispose them to have breast cancer as well. So those patients need to begin radiation 8 to 10 years after they've completed their treatment. So for example, if they finish their treatment at 18, they would begin mammography at age 26, right? But no later than age 25, okay? So that's, I'm sorry, no earlier than age 25. So 25 is like the number under which we should not be doing mammograms. And then coming to what you were discussing, we know that Ashkenazi Jewish and African-American women have a higher likelihood of, one, having genetic mutations, and two, having aggressive cancers. So what the American College of Radiology is recommending is that women who are Ashkenazi Jewish or African American should go for some type of lifetime risk assessment and like do an extensive evaluation of their family history and other risk factors to see if they should begin screening earlier than age 40. Okay, so to try to identify those high risk patients before they turn 40 in case we need to start impacting them early. So what is the ideal screening? So obviously it's going to depend on a lot of things. One, it depends on what type of breast tissue you have. So you may have heard of dense breasts, and we're going to talk about that a little bit later. So some patients who have dense breasts may need to have an ultrasound in addition to their mammogram. And then of course we have the high risk patients, which we discussed, right? And so some of them, if they're not very high risk, like having a genetic mutation, may need an ultrasound. Others may need MRI. So you know that all the BRCA patients need to have mammography and MRI yearly. And what we recommend is to stagger them. So what does that mean? So for example, if I get my mammograms in January, I should get my MRIs in June. And that way, every 6 months, I'm doing one or the other modality, okay? And then we have a new thing that's called contrast enhanced mammography, which is a mammogram with contrast. So it's a different kind of contrast than the one that's used for MRI. We use gadolinium for MRI. For contrast enhanced mammography, we use iodine, which is what's used, for example, for CTs, okay? So even though patients with genetic mutations should be having MRI, occasionally there's a contraindication for MRI. For example, they have an implanted device that cannot be used inside a magnet, or they're horrendously claustrophobic. I have a couple of them of BRCA patients who are horribly claustrophobic, right? And they just can't do it. So this is a good alternative, right? So contrast enhanced mammography. So let's talk about dense and fatty tissue. So we talked about the structures in the breast, but the way we see the mammogram, the breast tissue on the mammogram varies on depending upon the amount of fat versus dense tissue that you have. So this is a fatty breast. So you see how it's very dark? It's because fat looks dark on mammography. So finding this little cancer in this fatty breast is very easy, right? When my son was in the 4th grade, they invited me for to talk about careers. And I showed them this mammogram and I said, where's the cancer? They were able to point it out, right? Okay, so that's a no-brainer. This is a patient who has a little more dense tissue. You see how it starts becoming a little whiter. It's a little less dark, and still we can see this cancer very clearly in here. So this cancer, you see these little masses and some calcification. So that's easy. But what about here? So this patient has a very dense breast. So here you see the fat, and this is the dense tissue. This is all that ductal tissue, all those lobules, and she has a lot of fibrous tissue, which looks very white on mammography. So where's the cancer here, right? Not so easy, right? We really cannot see it. It's hidden. So I like to tell people it's like finding a snowball in a snowstorm. You just don't see it. So we need some more help on patients who have dense tissue like this. And so this is where that patient's cancer is, but this is what it looks like on ultrasound. On ultrasound, we see it very clearly. So for some patients, we need to do ultrasound, right? And then for other patients, we need to do MRI because MRI with the contrast shows us these active tumors. And so this is wonderful. So MRI is fantastic. And that's why for very high risk patients like the BRCA patients and patients with genetic mutations or patients who have multiple family members with cancer and who test negative, right? Which does not necessarily mean that they don't have a mutation. It might just mean that they have a mutation that we just don't know how to diagnose yet. This is what we recommend. We recommend MRI because it shows us a lot more than what a mammogram can show us, and sometimes even more than an ultrasound, or many times more than an ultrasound. So to conclude, screening mammography is still the most effective method for early breast cancer detection and increasing survival, okay? So it's the only modality that has been proven with randomized controlled trials. And you guys were talking about randomized controlled trials, so you know that that's the gold standard for identifying whether something works or not. But there are patients who need to have some extra help, right? Some more aggressive or more tailored screening, right? But still, at this point in time, we are not prepared to say that any of those other modalities can replace mammography, okay? So there's still something that we do in addition to, not instead of. And remember, the goal is to diagnose cancer when it's small. So because this is a BRCA strong group, right? Let's just kind of go over a little bit. I mean, you probably know this more than I do, but BRCA mutations cause 6% of all breast cancers. You know that these are small mutations located on the chromosome. So BRCA1 is on chromosome 17 and BRCA2 on chromosome 13. And what happens is that we have normal repair systems in our body, right? That should help reduce cancers. And what happens with these mutations is that that repair system gets broken. Unfortunately, BRCA patients tend to present with cancer at a much earlier age, at 40 compared to 61, which is the average population. And remember how we said that the average risk of having breast cancer is 12%. Well, in BRCA patients, it's much higher. So BRCA1, 55 to 65, and BRCA2, 45, okay? So there are special challenges, one, because they're younger. So what happens when patients are younger? Their breasts tend to be more dense. So normally over time, as you go into menopause, that dense tissue starts to decrease, right? And the breasts start becoming fattier. So the younger you are, the harder it is to find those cancers. And the other thing is that BRCA patients, their cancers tend to have a, quote, benign appearance. So unless your radiologist is experienced, he may blow off something thinking that it's a benign fibroadenoma when it might actually be a cancer, okay? So that's very important. In BRCA patients, our threshold for recommending a biopsy is much lower because we know that these cancers may not have the typical cancer appearance. And that's why, unfortunately, BRCA patients tend to have many more biopsies than patients who do not have a mutation, okay? So that's kind of just the way it works. So let's talk a little bit about pregnancy and screening. So it's been a taboo, right? We have always said that you do not get mammograms when you're pregnant. Well, because of the increase, we're seeing a trend in women becoming pregnant at older ages, right? So a lot of women are getting pregnant in their 40s. And we now know about a lot of BRCA mutations before patients get pregnant. Like before, we would only diagnose them when they had a cancer, but now because we're doing more genetic testing and there's more knowledge, there are many young women who know that they have a mutation even before they get pregnant. So this is becoming a very important topic, and breast cancer, which presents during pregnancy, has special challenges, right? So we want to be sure that we're monitoring these patients. So the American College of Radiology came out in 2018 with guidelines as to who should be screened and when they should be screened during pregnancy. And bottom line is we need to continue to do mammography during pregnancy. So just because you're pregnant doesn't mean you should not be screened. And the risk of radiation to the fetus is minimal. So it's less than 1,000th of what's considered the toxic radiation dose at which there could be effects for the fetus, right? And if you request to have the apron put on your abdomen, that further reduces the dose by 2 to 7 times. So there really is no risk to the fetus if you do your screening mammogram during pregnancy. Now, what is the ideal scenario? Hopefully, ideally, most people try to plan their pregnancy. So I would recommend, if you're planning on having your pregnancy and you're due for your mammogram, make sure you get that mammogram before you get pregnant, okay? That would be the ideal scenario. Do it beforehand. So that's mammography. Now, MRI, we can't. So the gadolinium, which is that dye, the contrast that we have to give for MRI, cannot be given during pregnancy, okay? So again, planning is important. So the ideal situation is to get your MRI before you get pregnant. I've had a couple of patients who've gone in to get their MRIs, and then we call them to tell them that there's something abnormal. They go, oops, I'm pregnant now. And so it becomes a problem. It becomes a problem. So not only do your MRI before, but don't get pregnant until you get your results back, right? And be sure that you're clear before you move into that pregnancy, okay? Because we do not want to do an MRI or an MR-guided biopsy, right? Because if we need to do a biopsy and we can only see it with MRI, you need to have that gadolinium. So that's kind of like the take-home point on that. And so you should follow your age-appropriate screening guidelines. So what does that mean? If you have a BRCA gene and you're 30, you should get your mammogram, okay? Any questions on that? Because I think that might be like the most shocking thing out of all of this, right? Okay. All right. And what about during lactation? So here, the problem with lactation is that because the breasts are so engorged with milk, it does make interpreting that mammogram a little more difficult, but we still should be doing it, right? So what I usually tell patients is, if you're just going to breastfeed for 6 months, finish your breastfeeding and we'll do your mammogram afterwards. Not because it's harmful in any way, but because it's going to make for an easier to interpret mammogram. But if, some people are planning, some people are still lactating for a year or 2 years, you should not stop your screening protocols. And you should do your MRI, okay? So there's no problem with doing MRI during lactation. And you don't even have to throw out the milk. So the gadolinium, that contrast, is not harmful in any way to the breast milk, so you don't have to throw it out. The recommendation for both of these during lactation is you bring your pump or your baby with you, and right before you go into that exam, you pump out those breasts, okay? Because we want that milk, as much milk as we can, out of the breast before we do the imaging, because that will help us with the interpretation, okay? That milk kind of makes it a little more difficult to do. And to your question regarding lumps during pregnancy, they're very important, okay? You don't know how many times we see patients with pregnancy-related cancers who come in and say, oh, I thought it was nothing, or, oh, I went to the doctor and they told me it was nothing. No, if it's a week and it hasn't gone away, you demand to get an ultrasound, okay? Whether it's during pregnancy or during lactation, because we need to be sure that, if it's a milk obstruction, that's fine, great, wonderful, you're done. But if it's not, it needs to be biopsied, okay? And biopsies are safe during pregnancy. They are not a problem. During lactation, there's a minimal risk of what we call a milk fistula, which is that you might have milk leaking from the tiny biopsy incision for a while. But compared to letting a cancer go for months, I mean, that's a minimal risk, okay? So, and here you really do need to go to an experienced radiologist. And again, because these cancers sometimes may come with a benign appearance. And so you need someone who will say, okay, we need to biopsy this, and who will not be afraid to do that biopsy. So that's important, okay? So remember, I mean, BRCA patients should know this, that there are other cancers related to genetic mutations, and they require screening as well. So the ovarian and fallopian tube cancers may benefit from early screening with pelvic ultrasounds and CA-121 levels. These are like tumor-created substances that can be detected in blood. There may be an increased diagnosis of pancreatic cancer. So some patients will be offered like screening of the abdomen. Males with prostates should start screening at 45 for prostate cancer. And because of link to colon cancer, you may be offered having colonoscopies as early as 40, okay?
I
Compared
have
to
a question.
Sure.
On CA 125s, are they accurate screening levels?
It's a very tricky thing, right? And unfortunately, the problem with ovarian cancer is that there really is, we don't have a good way of screening for it. Unfortunately, by the time we detect it, it's usually more than just early stage. And so these are the only two things that we can do.
Okay.
Okay, so they're not accurate. They're not horrendously accurate, right? But there's really nothing much better, right? And BRCA2, remember that they may be associated to melanoma as well. So you may be going for skin checkups, okay? So good question is, when do you stop screening? Okay, and that's always a good question. Any thoughts on that?
You should never stop screening, right?
Well, so if you're 85 in a wheelchair, had a stroke, and your kidneys aren't working, should you be screening?
No.
No, right? What if you're 45 and you have an end-stage pancreatic cancer? Should you be doing breast screening?
Yes.
Yes? No.
No.
No. No. So we screen to try to reduce your mortality due to breast cancer, but if you already have a very short life expectancy because of some other condition, you're not going to benefit from screening. Okay? So what the recommendation is, you should screen until one, you think you're going to do something about it if it gets diagnosed, right? Because, for example, I've had patients in their 80s and I tell them, look, you know, they come in for their mammograms. I'm seeing some new calcifications. We need to biopsy them. Are you kidding? Even if it's cancer, I'm not going to do anything about it. So don't ask for what you don't want to know, right? So if you're not going to do anything about it, don't come get your mammogram. So that's the first thing, right? Two, are you healthy enough to be treated, right? Because if you're in a very precarious situation because of something else, then, and you can't be taken to the OR to have a tumor removed, then you should also not be having screening, right? And three, if your life expectancy because of something else that you have is less than, so the recommendations go from 5 to 10 years, right? If it's less than 5 to 10 years, then maybe you should not be having screening either, okay? Because we're not gonna benefit you, okay? Does that make sense?
Yes.
Okay.
And I have a question. Maybe you can touch on like follow-up screenings after you have a mastectomy.
Okay, so that's a very algid subject. And so the consensus is that once you've had a mastectomy, you should not be doing screening. Okay, and the reason is, so if you have a reconstruction, right? If you've been reconstructed with an implant, for example, the implant should be placed behind the muscle, right? And so if you do have a cancer, it should be easily felt, right? Because everything is going to be like right next to the skin.
Mm-hmm.
I mean, correct? So it's not going to be hidden behind the implant. It's going to be between the implant and your skin. So it should be easily palpated. So that's the first thing. If you don't have a reconstruction, if you don't have an implant, then it's just the chest wall, same thing goes, right? It should be very easily felt. If you have a tram reconstruction, right, like a flap reconstruction, it gets a little more tricky. But what most studies show is that there's no added benefit to doing the screening. When we start screening these patients, what happens is that we end up doing a ton of biopsies and we're not really impacting survival, okay? So even though it might give the patients peace of mind,
Mm-hmm.
at the end of the day, the early diagnosis in that situation may not be as beneficial as in those patients who have not had a mastectomy, okay? That being said, if you have a lump, we need to see it, right? Okay, so it's not, don't pay attention to lumps, but we don't screen, okay? If you have no symptoms, if there are no worrisome clinical findings, we should not be screening. That's the current point of view. There's a lot of controversy on that. That might change over time, but at this point in time, that's the thought. And the other thing is that, unfortunately, when there are these extensive reconstructions, patients have a lot of scarring, and that scarring is sometimes very difficult to differentiate from cancer. So that's why they end up getting a lot of biopsies. Okay. So, is it safe to screen now with COVID? Absolutely. Okay, so for a couple of months, we thought it wasn't, and the American College of Radiology and all the major societies decided in unison that it was more dangerous to be exposed to COVID than to put off screening for a couple of months. But we know more now. All of our facilities are protected. Make sure you go to a safe and reputable place where you know that they're going to take appropriate measures. Everyone is wearing masks and shields. Equipment is being scrubbed down after every patient. And so no, it's time to move on. We need to move forward with our lives, and we cannot put off screening any longer. Okay, so we are concerned with patients skipping their mammograms and not coming back. So we need to see you again. Okay, so very important to not medically distance. Okay. All right, and male breast cancer, just to briefly touch on it. So we know it's much less common than in females, but again, much more likely in patients who have genetic mutations, right? The BRCA1 and 2. And this kind of goes in with the whole theme that you can have a BRCA mutation without having had breast cancer in your family. So if your BRCA mutation is being passed down on your father's side, it may be a lot harder to find that family history of breast cancer, right? Because males are less likely to present with breast cancer. And then there are families where your BRCA mutation will, is more likely to show up as ovarian cancer. And that's why we ask about all these other cancers, right? So sometimes we detect a BRCA mutation in families where there have been pancreatic cancer, or just ovarian cancer, or just prostate cancer. So it's important to remember that there are other manifestations, and that when it comes down that male side of the family, it's a lot harder to trace. Okay. Treatment is going to be the same as for women. The recommendation is to start clinical examinations at age 35. And at this point in time, we do not recommend mammographic screening for patients with BRCA mutations. Okay, and the reason being kind of similar to what happens with the reconstructed patients, because they don't have breast tissue, they should be very easy to palpate. Okay, so that's the current recommendation. Prevention: avoid obesity, exercise regularly, reduce alcohol intake, right? Try to eat healthy, especially low-fat diets, especially saturated fats, lots of fruits and vegetables, and know your family risk factors so that, and know them when you come to get your mammogram, because that helps us help you. That helps us decide what is good for you. Sometimes, many times, because there's not that much of knowledge in the family practice or the general practitioners about these risk factors for mutations, we in radiology are the ones who pick it up. And we pick it up by asking these questions. So help us help you so that we can identify this. And if it ever happens to you, you know that there are many new and effective treatments. It is important to come to academic centers because of clinical trials, what we were discussing. So you're much more likely to be offered a clinical trial if you come to an academic center than if you don't, right? Make sure that that's there when you decide, when you elect to get treated. And there are, in general, more advanced treatments, okay? And never lose hope, okay? So if anything has improved, and if anything has hope, it's breast cancer. There's so much out there that we can do, so many second, third, fourth line treatments that we can never lose that hope, okay? So, what happened? Why did this, okay. So let's take our quiz again. Now that we've, okay, so you got most of these right? So screening does not, false, right? When should women begin? So average risk at 40, but you correctly said it depends, right? How often? Every year. All breast cancers are the same, false, right? Probability of surviving breast cancer does not depend on the size of the tumor, false. Most people who get breast cancer have a family history, you knew that, false. Should never be performed during pregnancy, I want to hear it.
False.
Very good. Okay, false. All people who have genetic mutations have a family history of breast cancer, false, right? So when should I start?
40, or depends, I
No,
guess.
with a genetic mutation,
Oh,
30.
25 to 30, right? You're in trouble, Missy.
I see.
Mammograms are enough for all patients, false, right? Okay, very good.
So I have a couple questions before we close out, and I don't know if Dr. Lucette does, but one question that I get a lot from women is like, what if we have discharge or blood coming from our nipple?
Go to your doctor.
So, like I had a woman yesterday contact me who's in Australia, and she's like, I woke up and I had blood discharge and I had discharge. I'm like, go to your physician immediately.
Right.
And obviously, different places have different facilities to work and, procedures. So she's like, is there anything that I could do? And obviously, as she started Googling it, it freaked her out. So definitely discharge and blood are obviously signs that they.
So interestingly, the most common cause of bloody discharge is a benign thing, right? It's called a papilloma,
Okay.
which is a benign tumor that grows inside that duct, right? And so what it does is it kind of erodes. Imagine a little wart. They're like little warts growing inside that duct. And so it erodes the tissue and it causes bleeding, right? And so that's the most common cause of bleeding. But obviously, we're always thinking that it might be cancer. So obviously, that patient needs to have a mammogram, needs to have an ultrasound. Sometimes mammograms and ultrasounds don't show the cause for the bleeding. So you may need to have an MRI. And some patients will continue to have bleeding even when there's nothing on any imaging. And those patients need to go for surgical. It's called surgical ductal exploration. So the surgeon goes in and he finds the duct that's bleeding, and they go in with like a little probe and they kind of like pull it inside out and examine it to make sure there's nothing there, and they'll cut it off, they'll ligate it so that it stops the bleeding, because sometimes we never find the cause, and they need to do that to stop the bleeding, okay? But definitely need to pursue it, okay? That's not a normal thing. Now, there's another thing that's interesting, and during pregnancy, it's not very common, but it does happen. It's called the rusty pipe syndrome. Imagine that. And so sometimes that benign, so remember those cells that I showed you on the very first slide growing inside? So there's like a proliferation of those cells and they start bleeding because of all those hormones and things. And so that's what they call it. It's called the rusty pipe syndrome. So, yeah.
It's interesting, these syndromes names, I must say.
Okay. Anything else I can help you with?
I have a quick question. I mean, I don't know if it's a question as much as it is a comment, but when you see women in your office that do have breast cancer and they did not get screened for a long time, what are the most common reasons? I mean, is it because of access? Is it because of fear? What do you think gets in the way the most?
So I hear a lot about insurance, right? Oh, I didn't have insurance. Others are just afraid. I mean, you don't know how many times people have been sitting on these things for years sometimes. I mean, years. Mm-hmm. And interestingly, you would think that it only happens in uneducated, like poor or, low resource patient. No, I mean, denial is an amazing thing. And magical
thinking of it's not going to happen to me. And yeah.
I've seen patients, you know, from all walks of life. I mean, educated, with educated families, and with neglected cancers. I mean, family finds out when there's really nothing left to do. I mean, it's just it's amazing. And I think it's denial. It's fear, denial, like not wanting to hear the truth, and you know.
Yeah, no, and I think that's definitely something we need to address as a society in terms of the language that we use and the marketing campaigns, because I mean, there's access to care is one thing, but I think the fear element is pretty strong. And just the same way it is with, you know, smoking cessation, and how those like really scary, like graphic pictures were eliciting a lot of fear, and they were like, they were not
conducive to
they were not conducive to change. Like, kind of what language are we using? And I think, you know, I'm thinking even like myself in sessions, or like, how can we help with those fears, because that's going to be very important.
I mean, I think it's trying to remind patients, you know, the earlier the better. I mean, that's the smaller the better, right? I mean, a pea-sized thing is much better than half the breast or more, right? Which we see. I mean, we see these things. So it's important. It's important. Yeah. Yeah.
I think fear is a huge piece of mammograms. We hear it from a lot of different women, like how painful it is, how they're scared to go in, they don't want to be compressed, or they just don't want to know because there's no breast cancer in their family. We had a recent lady who was just diagnosed, and she is stage 3. They're not sure if it's metastatic yet. It's borderline. And she's like, I just kept putting it off because I was scared, and my family didn't educate me. My family never told me, you know, there was cancer, we needed to get screenings.
No, and even if there isn't, I mean, I hear that all the time. A patient who comes in, but I have no breast cancer in my family. This isn't going to be anything. We have to do the, but why? There's no cancer in my family. Doesn't matter. 75% of breast cancers occur in patients who have no family history. 75%. I mean, that's huge. So, and who have no risk factors. So, I mean, we really do need to reach out to that population who is fearless. You know, unfortunately, lack of fear is also a bad thing, right? You know, you have to have a little fear.
Yep.
A little fear is good because it makes you do what you need to do.
Very true. Yeah.
Okay.
Well, Dr. Yepes, thank you so much for coming on today and sharing all this information about MRIs and screenings for Breast Cancer Awareness Month and National Mammography Day. I will make sure that this recording gets heard. We will post it on our YouTube channel and send you a copy, and share it in our personal and private groups so we can continue to educate the community.
Absolutely. Okay, it was a pleasure. And you guys were very good students.